Hello, I'm Nick Klensky, reporting for Daily Bulletin. I'm talking with Dr. Michael Hartung, Assistant Professor at the University of Wisconsin. He is sharing key learnings from his RSNA 2022 session, CT Without Borders, Comparison of Emergency Department Abdominopelvic CT Diagnoses from a U.S. academic medical center with the teaching hospital in rural Kenya. Thanks for joining me today.
Thank you.
To start, could you tell us why you decided to study abdominopelvic CT diagnosis between a U.S. and a Kenyan hospital?
Sure. So I've had the privilege of being involved as a volunteer with a group of other radiologists that support a hospital in Kenya called Tenwick Hospital, which is the rural Kenyan hospital in the study. And I'm also an assistant professor at the University of Wisconsin. And over time, I've become curious about the difference in diagnoses and what I've observed there versus at my own institution. In particular, at the Kenyan hospital, I saw unusual or uncommon diagnoses in later presentations, more advanced pathology, and more cancer diagnoses. And so I became naturally curious as to what exactly were the differences between the institutions, and then thinking about how that might spur greater interest in program development or potentially opportunities for supporting the hospital, but meeting them where they're at with their specific patient populations rather than coming from the perspective of my own institution.
And can you give us a brief overview of your study and its results?
Sure. So we took 750 patients from both hospitals who had an abdominal pelvic CT for abdominal pain, and we compared the diagnoses. The mean age between the two institutions was more or less the same, around 52 or 53 years old, but then from there the differences really emerged. So at Tenwick Hospital, which is the Kenyan hospital, we had very few comparison studies, a low baseline rate of known cancer, a lower negative rate of studies, and a much higher rate of new cancer diagnoses. Almost 40% of the whole cohort had a new cancer diagnosis. At UW Hospital, in comparison, we had about 60 or 70% of the patients had comparison imaging coming in the door, so had been already plugged into the healthcare system. We had a higher rate of negative studies, almost 40%. And then from there, the majority of the patients had an acute abdomen diagnosis with very few new cancer diagnoses. So quite a few differences. But then despite those differences, when we compared the top 15 diagnoses, 10 were shared between the two institutions for acute abdominal pain. So the unique diagnoses for Tenwick Hospital included tuberculosis and hydatid disease, which are rarely seen in the US. And at UW, we had some other diagnoses that are commonplace for us, but actually quite rare, probably based on diet, such as diverticulitis and constipation. So those were common at the US, but not common at all at the Tenwick Hospital.
And what will this data provide to academic programs or organizations looking to develop global health partnerships of their own?
Yeah. So certainly volunteering and looking at the data in this setting has helped me to recognize some of my own biases with just how I practice radiology, or what I think, when I see a patient come in with abdominal pain, the most common diagnoses that I start to think about, and it's challenged me to think contextually about what sort of diagnoses that they're facing and more common at their institution. So drilling down and looking at the specific numbers and the specific types of diagnoses, I think it's helpful to challenge your own institutional biases, and then stepping back and recognizing that a lot of the radiology resources and literature is written from authors from developed Western, often US settings, and realizing that taking that perspective and applying it to low to middle income countries may not always be as effective. So when I think about this practically, if we wanted to help to support an abdominal fellowship or abdominal training program, instead of just going in and kind of rattling down the diagnoses that we see more commonly, now we have some data to consider how we might adjust our educational plan to suit the institution. So we'd focus on things like tuberculosis, hydatid disease, more advanced presentations of disease than we would typically see here and at our institution.
Well, thanks for joining us today. For more information about emergency radiology, look for this RSNA 2022 session on demand. And as always, you can find more radiology news at rsna.org/bulletin.